legal aspects should be very supportive for this. However, this is not true. And we are facing a lot of obstacles for many, many directions of our development. Also for the reconstruction therapies, for the embryology side, and also even for the stimulation side. So most of the clinics and doctors will still keep stimulating patients and will strongly believe in the fact that the follicular phase stimulation is the best approach and the only approach. However, for many, many years, long time ago, it was started as an option for the oncological patients, because for oncological patients, we had no time. And once they were detected with the oncological disease, we had to freeze their oocytes or the ovarian tissue. However, not every center can freeze the tissue. And we started the approach to stimulate patients, calling this random start stimulation or the luteal stage stimulation. And having more samples, like more cycles of those stimulations, we understood that there are benefits coming from this stimulation and the outcomes are totally same or even sometimes even better. But of course, we understand the differences, and there are differences there. However, due to the regulations and due to the fact that some clinics and some countries, they are very conservative, and they kept being very conservative, these numbers are not growing as fast as we would request. So that's why still data will be a little bit limited. However, it's already there and we understand much more. And however, the most important is not to make any risk for the patient. So safety first, always, and this is also our priority, of course. If we are talking about patients in advanced maternal age, but not only about advanced maternal age, our approach is always to select individualization versus standardization. Standardization is important for the clinical management, for the algorithms, how people should act, what they need to do. However, for the treatment process, we are always from individualization. If we are talking about some parameters, because as we said, that everyone is different in advanced maternal age, or even if we would select now 10 women in their 44, and if we will check the parameters of the FSH, IMH, estradiol level, cycle frequency, fact of the ovulation, antral follicle count, and will recommend them standard protocol, what we will not do, but even if, so the outcomes will be totally different. However, there are some average values, and specifically, I would like to talk here about the declines. This is something what has been already calculated and presented, and one of the most reliable markers for the ovarian reserve is our anti-Muller reserve, and we used to count it as the numbers like nanogram. There can be picomoles, of course, in some of the countries, but most often is the measurement in the nanogram per milliliter, and the decline per year would be somewhere between 0.3 for the patients less than 30 years old, 0.5 between 30 to 35, 0.7 after 35, and 50% less every year for patients over 40 years old. If we understand that we are less on 50% every year in the age over 40, meaning we need to be really careful and we need to take care about every follicle which we may potentially have. And this is what we are doing in using our approach. We are focusing first on the primordial follicles. We need to understand what our real reserve is, understanding the fact that some follicles will be already apoptotic or they will be not potential because of the presence of the TECA and the granulosa cell and the receptivity and everything else, what is important in terms of the follicular genesis, because it's also a fact that it has been proven by doing the histological evaluation of the ovaries of the patients in the perimenopausal period and the menopausal period that once they started their menopause, total number of about 1,000 follicles, primordial follicles, still was there in the ovaries. So the follicles were there, and either the process of the development was not working, or those follicles were not, the process of the activation was not working. So either we need to solve the issue, and we may say thousand is a huge number, right? And this huge number, however, we were wasting during our lifetime millions of those. But even if we still are having thousand, this is really great. But either we need to think about the process of the activation, or the process, like the apoptotic potential. There should be something external what will boost that development and will start to calculate our time backwards. Is it possible? Like, what are the options? We will be discussing those options right now. So what we have been using for many, many years already, that's platent-rich plasma. And there is a lot of discussion about this approach, and recent publications are mostly against this treatment because patients started, and we can see this paradigm, that patients started to push doctors to perform that treatment. However, it's understandable about the potential of this solution is quite limited. So still we need to have those numbers and those conditions in the ovaries for the fact that the platent-rich plasma only will be a working solution. And for some patients, depending on the inclusion criteria, that will really work well. And we have a lot of evidence about the fact that only PRP works really well. However, not for every patient, of course, and the initial criteria will be the most important about to define either the PRP only will be the solution. Next step is, and also it's very important for neither of this treatment, either PRP or the exosomes or the stem cells, the follow-up process after the fact that we started the process of the ovarian rejuvenation should be very thorough, and we need to do it right, uh, frequently enough, effectively enough, and being able, once we need to act in accordance with what's going on in the ovaries, we need to prioritize that treatment. If we are able to prioritize that treatment, we will be really successful. We want to catch every potential follicle which is growing. And if we have ability for this, it's not always easy. We understand this because of different circumstances. But if this is controlled and if the follow-up is performed, patient always will be successful, based again on the initial parameters, but still it's very important. The next step, and something what we will discuss the most in the details during this conversation today, this is ovarian rejuvenation with the exosomes. And the next level, something what is still the most, and even for us, we are learning a lot about this process, but for us in our practical experience, this is still quite limited. And we will be discussing about the differences and the fact that this cell-based treatment, that's the ovarian rejuvenation using the stem cells. Which problems we wish to solve in terms of the ovarian aging, patient aging, oocyte aging, and as a fact, impact on the final outcome as the embryo development, maturation potential, cytoplasmic nuclear potential of the maturation, and so on and so forth. So with age, we drop the number of early primordial follicles. This is what we discussed because they were spent during our previous menstrual cycles and the ovulation cycles, so on and so forth, an increase in follicular destruction. So this is intracellular mechanism, a decrease of the number of the apoptotic follicles, the inability of follicles to respond to the gonadotropin stimulation. As a fact, also for the oocyte, we are facing huge impact on the negative approach on the fact that we are decreasing the mitochondrial DNA levels and their activity. there are morphological changes in the oocyte. ITF production is low, oxidative stress is very high. So hormonal replacement therapy has been the first line strategy. However, this contradicts with the approach for the stimulation, because if we are supplying estradiol, we are suppressing FSH production. Once we are hormonal replacement therapy, we may preserve somehow in like still preserve, but not preserve for 100%, but make it better in terms of not losing so many follicles during the cycle. However, if we want to start the stimulation, we need to stop hormonal replacement therapy and then to start working with the exogenous or the endogenous FSH. And this hormonal replacement therapy was the fine strategy. However, now the novel treatments are the stem cell and the exosome therapy in order to solve these problems. And I've been searching about the number of the companies which are producing exosomes. This is from one of the publications, and they are over 60 right now, and the number is growing and growing. And most of those companies have started their like they either switch from they've been doing some different functions before, so they added the direction of the exosome production to their activities, or they just been organized within last 2 years. So we just may assume what will be happening further in this direction. But in general, the exosome treatment is the non-cellular therapeutic strategy, and this is important to talk about the non-cellular as to understand the difference within the stem cell treatment that takes an advantage of the biological potential which characterize the exosomes, which are the nano-sized extracellular vesicles which are released by the cells. And the exosomes we are using for our treatment are released by the mesenchymal stem cells from the umbilical cord. So they are rich with the protein, with the nucleic acids, with the growth factors, and the other many biological bioactive substances. They affect, if we are talking about intra-ovarian treatment, which is also we highly recommend to focus specifically on this. We can combine this with intravenous infusion of the exosome. Of course, this can just boost better and overall activity of the exosomes. However, we are focused on the ovarian microenvironment and in order to promote the ovarian granulosa cell proliferation, because they are important for the follicular development, tissue regeneration, and improve the mitochondrial function. They also suppress the apoptosis, as in general, and upregulate the anti-Muller hormone and the FSH receptor expression. That's why we will be monitoring the hormonal status of the patient in order to understand the effectiveness and activity of the exosome treatment. The bank, stem cell bank, from where we are getting our exosomes, which we are using in our treatment, that's Embryyo, which is located on the periphery of Istanbul. That's a closed zona, which is under the protection of the government of the Turkey. And the Embryyo is the partially governmental, partially commercial bank, which has 2,400 square meters of the closed area. So in order to drive a car in, you need to register in advance. You need to provide the information, who you are, why you are coming, what you are going to do, whom you are going to visit, what's the purpose, so on and so far. Then parking the car, entering the building. I gave my passport in order to get a card and to get into the laboratory area and the administrative areas. I've been able to visit only Class D quality control areas, which are just storage facilities, which is quite similar to our embryology laboratory, but just the number of tanks and their volume is much bigger, because Embryyo is storing tissue, so they have organ bank. they are cord and the placenta bank, and they are also production of the different cell products. So most of the laboratory, they are class A production areas and class B clean room preparation areas, which is altogether 100 square meters with over 100 biologists, genetician, molecular biologists on staff. And they are sending biological materials which are produced to different destinations, but mostly also inside Turkey as well, but to different countries as well. They are FDA regulated since this year, 2024, and also a lot of ISO for the quality control, of course, but also for the environmental and the health and safety management, and they are European Association approved as well for tissue and cell banks. In terms of the preparation of the patient, for our treatment, we recommend, and this is how we used to perform our treatments before, we do combination of the exosome treatment with the PRP. Because having a lot of data about the fact how PRP acts and the growth factors and the activation of the angiogenesis and all other active moleculars, this is and safety in terms of the fact that this is own plasma of the patient. That's why we also consider that the exosome are much safer because they are non-cellular composition compared to the stem cell composition. But also technically, once we are injecting 2 milliliters or let's say 1 milliliter of the exosomes into the ovary, our needle is long, and in order to inject the whole volume of the exosome, we are flushing our needle with the PRP. So we combine two regenerative solution in order to increase the efficiency, to combine physically their mechanism of action to activate better. So that's why we would collect the patient blood in order to prepare the platinum-rich plasma, and we will prepare the exosome solution and will inject them into the ovaries of our patients. Usually we inject them as a combination post egg collection because many of our patients, they are traveling from far away, and we decide to use the potential of their ovaries to respond as much as they can, and then to combine one treatment as a egg collection and the rejuvenation technology, because for most of the patients, we would have several stimulation rounds. So that regenerative potential will be active already for the next stimulation rounds. This is just briefly about the PRP, forcing the angiogenesis and vasculogenesis, regulation of the inflammatory process, the cell growth and the proliferation, and so on and so far. For the exosomes, they are important in terms of how they are produced, and I've got a huge lecture about the fact how they are produced. So they are generated through the fusion of the exosome containing endosomes with the plasma membrane from the cells. And then they have this ultracentrifugation, ultrafiltration, precipitation, immunoaffinity capture, and then the size exclusion chromotherapy. So as a result, we are getting 5 billion exosomes. We have two different volumes. So for intra-ovarian treatment, we are getting 5 billion exosomes in 2 milliliter solution. And for the IV treatment, there is an option of receiving 5 billion exosomes in the 5 milliliter solution. So the concentration is same, and this 5 billion for intravenous infusion, this is the same concentration as they are recommending for all kind of beauty procedures. However, for the ovarian injection, this thing would be discussed, but they started to do quite recently. they concentrate them because it's not possible to inject 5 milliliters solution into the ovary of the patient in advanced maternal age. Between 1 to 2 milliliters, this is something what is very optimal, and 5 billion in the treating active solution, this is something what we really would like to get. However, a good combination is to combine both. We do not support to consider only intravenous treatment, because obviously, how can we be sure that those exosomes will start acting specifically in the ovary, but they will not select to move into the brain or the heart or the kidney or the liver, which are considered to be more like organs which need more functions and more activations, and that they will be definitely have more priority than the ovary. In terms of the status and the impact of the exosomes, it has been reported that the hormonal response, oocyte differentiation, follicular development, and the meiosis onset pathways have been regulated with the exosomes. And also a lot of publications. They are animal models, all of them, but they demonstrated the variety of the microRNAs, which are very specific, which directly regulate the meiosis and the maturation of the follicle. So understanding the fact that the exosomes will not help to generate new follicles in comparison with the stem cell, which potentially may have that effect, but the exosomes will work hardly on those follicles which always are present in the different stages of the development in our ovaries, even if we are in the period of the menopause or somewhere close to that period. So for whom we have been using, or for whom we still recommend to use the exosomes? For the patients who are up to 1 year in the menopause or who are in the perimenopausal period, patients in advanced maternal age with the premature ovarian insufficiency, premature ovarian failure, who just wish to boost their response before having the ovarian stimulation and to shorten the period of the stimulation outcome and the number of the stimulations for the family planning or for preserving the menstrual function. What we recommend to control as the follow-up after the injection, this is the FSH level, IMH level, estradiol level, antral follicle count, size, and the volume of the ovaries. In terms of the differences, so as I said, we are learning a lot. However, the huge difference is the fact about the cellular composition and the fact that either PRP is the endogenous or the exosomes are non-cellular particles. They have less risk comparison to the stem cells if those stem cells are not coming from the patient. Like, it's possible, and we have discussed the potential to receive own stem cells. However, technically, this process is quite complicated, but we are developing this potential, and I believe soon we will be also offering this to our patients, because there are patients who will need, like as I said, PRP, this is stage number 1, exosomes, it's stage number 2 in terms of the efficiency and the impact on the regenerative potential and the result, but the stem cell is the third option and really effective. And for some patients, that will be the option where we should start, or we can start with the exosomes, but then we need to consider that we would need to proceed with the stem cell treatment. In terms of the follicular development and the challenges, it's the fact that if we are having a reserve which is coming as the small antral follicles in the beginning of the menstrual cycle, still we need to understand those follicles may have different potential and they will respond differently into the ovarian stimulation. That's why we need to start the stimulation. We can support them with the different alternatives in terms of selecting the protocol, administrating the dose, individualization the dose. However, option of dual stimulation and luteal phase treatment is something what is always recommended to the patients in advanced maternal age, because this gives a physiologic way for those follicles which are in the different stages of the development to be ready and perfectly mature for receiving or for producing healthy and viable oocyte. If you're talking about when the regenerative solutions will be working, or for each stage of the follicular development, stem cells, they will be before the process of the activation, because they are potentially helping to grow new primordial follicles. They may differentiate into the different tissues where they are developing. So if they are developing in the ovary, they will be developing primordial follicles. But the exosomes and the PRP, they are working during and after the process of the activation with the present follicles which are already in the ovary, and during the process of the next 3 months. So PRP used to be proven as the solution which worked immediately, almost immediately, impacting the development of the secondary follicles. So within same cycle and during the next cycle of the however, the exosomes, they have a little bit longer mechanism of physiological activation, and they are impacting the development of the primary follicles as well, including the development of the secondary and the early antral follicles. So their lifespan is much longer and the mechanism of action is different. So we believe that the combination really works well in order for the patients, if we still don't want to delay the treatment process and the stimulation process after the activation and after the regeneration treatment. For the stem cells, we need to wait longer, because we need to wait the whole cycle of the follicular genesis, which is starting from 5 to 6 months. Then we might start to see the development and we will be controlling what's going on. However, as I said, thorough monitoring is recommended, because we are not switching off something what physiologically is given, and those follicles which will be growing, because they will be growing. We are not starting from point zero. We are just boosting from the point where we are starting, but still we need to follow what's going on in the ovaries and try not to lose any potential follicle which is potential for the development. That's I believe that for the Duo-stim or for the luteal stage stimulation, we need to talk specifically, because there is a lot of questions about this and a lot of things to discuss. However, I have a lot of evidence, and I really believe in the fact that if we have the conditions, and the conditions are the fact that the follicles are present in the beginning of the stimulation. We are always starting follicular stage stimulation. However, the disadvantage there is asynchronic growth, and the fact that we need to focus on the major cohort of the follicles, which will be effective and which will potentially produce mature and viable oocytes. And sometimes this cohort is a middle cohort, meaning we have one leading follicle, which better to leave it and to understand that we haven't catched that oocyte. But second cohort will be, let's 3 follicles, and then the third one will be 2 follicles. So we will focus on the second cohort, triggering the second cohort, but then 2 other follicles, they will be still potential for the luteal stage stimulation. But some of those will be so-called empty, or they will have predominantly apoptotic risks. So with the very small numbers, sometimes it's disappointing, because having 2 and being able to retrieve just 1, or having 2 and retrieving none of viable oocyte, this is really disappointing. However, we have some factors as how they were growing, how they were responding, how many days were needed for that development, what was the active dose of the gonadotropin. So understanding all this, still we can assume if you are going to be effective or not. That's just the explanation about the follicular waves and the fact that we can start stimulation at any period of the cycle. And we have had patients for whom we were able to manage 3 stimulation rounds within one menstrual cycle, even not 2, but 3. And this is something what is indeed physiological. And it's also possible. And this is the data of showing the patients and the correlation between number of the oocytes retrieved and the patient age. So you can see that while we are getting older, number of the retrieved follicles or number of the retrieved oocytes is less and less. However, after we started to use the regenerative treatment, it became totally different. So we were able to boost the potential and we were able to change. Not for all, it's still very individual. However, for majority of the patient, that was really, really effective treatment. And we were amazed with the outcomes as well. So this is a few clinical cases I wanted to share with you. One of those, I really, that was something what was quite on the beginning once we started our Exosome treatment. A patient who had 5 IVF cycles before, between 2021 to middle of 2023, and the maximum, which was like long time ago, for the like 3 to 2 years ago, maximum number of the oocytes retrieved were 4 to 7, and she had no viable embryos for the embryo transfer. But having embryos, this is a different story. So now we are focusing on the receiving the oocytes, number of the received oocytes, and their morphology. So because of having no viable embryos, this is a patient for the maternal sphincter nuclear transfer, and she started the treatment with us in the end of 2023. Maximum number of the zygotes, so oocytes collected, were 5 in 3 different cycles, almost 1 month after another. And then we decided to offer her exosome treatment. And we performed intra-ovarian exosome treatment for that patient, injecting 2 milliliters into each ovary because her ovaries were quite big. So she's relatively younger than most of our patients. This is also true. And then after 3 to 4 months, so that was not immediately, after the treatment, we had another cycle in which we already received 6 oocytes, but that was not significantly different compared to 5 oocytes in the previous rounds, and 4 zygotes. However, after 1 more month, we were able to double the number of the oocytes. And then again, after almost 1.5 months, we were able to retrieve 8 oocytes. We continued the stimulation with these patients. And again, after 6 months post-treatment, we are receiving 4 oocytes. Recently, we had another cycle, but we modified the dose a little bit due to the wish of the patient. So last cycle, we retrieved only 2 oocytes. However, that increase in number was really significant and really amazing. Just we need to understand here that she is a good responder. So this is one of the examples, but this is just to show that the treatment really, really works. And another case, one of the oldest patients who had a treatment with us. So 3.6, this is picomole. In order to get a number in nanogram per milliliter, we need to divide this into 7. So it's less than 0.5 IMH. And she had treatment in 2023, receiving 2 oocytes, but quite competent, receiving 2 zygotes. And then, sorry. And then at this treatment, she got PRP and the exosomes. And then after that was the luteal stage stimulation, we had again 4 oocytes and 2 zygotes. There was an issue with the treatment is expensive, so we decided to proceed only with the PRP, no exosomes. However, still after several months, we repeated the treatment, and it's important to say it's 48-year-old patient, which we would expect after almost 3 to 4 months is to decline her potential to respond and having the same number of the oocytes. We would expect that every 3 to 4 months we will be 1 oocyte less. However, we were 1, 2, 3 oocytes more, and within 4 stimulation rounds, we were able to retrieve 15 oocytes from the patient in 48 create 11 zygotes. She completed a reproductive transfer with the wonderful outcome of 46% of the blastulation and 60% of the euploid blastocyst outcome. So those are really motivating examples. We have more, but for many patients, we are still in the process to understand the treatment and to complete several treatment rounds to be like a perfect clinical case. But in general, um, while using the ovarian rejuvenation techniques in our practical experience with the combination of the exosome treatment and the PRP, we were able to increase the oocyte yield. We enhanced the embryo quality, but here this is a part which is embryology, and still I'm not saying that we were not trying to give an opportunity for those oocytes to be fertilized using just regular IVF. Still, we believe that these technologies are not that far deep in order to change the morphological development of the embryos and the quality of the environment inside the oocyte. So we are focusing now on the environment of the ovary, not the environment of the oocyte. Oocytes still need a bit more help, and it's not a magic, but we used to call this magic, but we know this is a science in terms of the oocyte reconstruction, spindle transfer, and the pronuclear transfer, the most effective for sure, in order to save every potential oocyte and to create as many euploid blastocysts as possible. But definitely the fact that the ovarian rejuvenation treatment will reduce number of the IVF treatment. So less treatment rounds would be required that will lower the emotional and the financial burden of our patients. So talking today, we have already a lot to share. However, we continue our learning curve, our development, and different researchers. We communicate with different professionals in the field, not only in IVF, in order to bring more solutions for our patients and continue learning about the mitochondrial donation. If you will have questions, of course, I can answer them, but I believe that's already soon. This is our for that kind of techniques main facility for now. As you know, we are practicing in Europe, but because of the regulations, and I mentioned already that the legal framework is very important. So this is the place where we can do more, and that's very new and modern and great facility. And we are really thankful for the local team as well for managing everything so well and controlling and helping and so on and so forth. So personalized approach, this is something what we believe is the part of the success, innovative mindset, both from the clinical team and from the patient, being ready for try, being ready for investigate, being ready for still, because of the limitations. Most of these treatments, we used to say they are experimental or we need to act with them as they are experimental. However, there are a lot of proof and the evidence about them. And I may say, as I said, safety first. So we see that there is no risk about this treatment, and the compassionate care. This is something what our whole team is usually providing, and we are doing our best. we always are happy to improve. So if you see that we need to improve somewhere, let us know. I will be really thankful for this. So thank you for your attention, and please contact us if you have any other questions, and that's so on. I promise to be not too long, but it's not always possible. So now it's time for the questions. Let me know the questions you have. Yeah, so whoever has the hands up, I believe that I'm a host here still. So Khrystyna may help me. If you may. Hi, Khrystyna. We cannot hear you.
I have a question.
Uh-uh.
Yeah, you said
Please.
we can take the combination of the treatments. Can we take on the same time? Because as we're traveling from different countries, you said stem cell, PRP, and exomes. The combination is very good. Can we
Yes,
take it at the
we
same
can,
time?
yes, we can do the combination. However, we can combine the exosomes intraovarian, intravenously, and we can combine the PRP. For the stem cell treatment, if you want to prepare your own stem cells, you need to come in advance. We need to be able to get your tissue, most commonly this is the fat tissue, and send this fat tissue into the bank for the preparation process. It will take them from 6 to 8 months in order, 6 to 8 weeks in order to prepare the material for being ready and to inject either into the ovaries or intravenous. So we need to specify because of the concentration and the volume where we would like to inject those stem cells. And once the material is ready, within 48 hours, it needs to be injected. So there should be a courier who will be flying from Istanbul to Tirana. This is possible and this has been done, but this is very complicated, as I said, and quite expensive. So that will be 2 visits, one for the preparation for receiving your tissue, and then after 6 to 8 weeks, in the specific timing with the transportation options and so on and so far, you will be able to receive your own stem cells. You can get the stem cells from the bank. They will be ready, injectable. This is also mesenchymal stem cells from the umbilical. They are safe, so they don't need the actual image. This option is also possible. However, we had only 2 cases of that treatment for quite severe, like lost reserve patients with less than 0.1 of the IMH, and we are still following up about how they are dealing. So we have very limited data about using these stem cells. But from another side, we are developing now the cooperation in Tirana with the stem cell bank, but in order to be able to get the fat tissue and to prepare the fat tissue. So for this, we need a special centrifuge and special piece of the equipment to prepare this at home in the clinic and then to inject it back. So if that it will be possible, within 2 hours, we will be able to prepare the stem cells from the fat tissue and inject them back, but it's not yet ready. So what you can combine either the stem cells from the bank, that will be mesenchymal stem cell, exosomes, or the PRP. Or you can combine intraovarian with the intravenous.
Actually, your voice is breaking in between. Let me confirm again. You said if it's a self, it'll take time for the stem cells. Okay, whereas if it's from donor, can we combine all three in the same treatment? Can we take on
Then
the
we will
same?
Yes, we can combine, but if we are talking about combination, then we would combine exosomes and the stem cells. We would not combine the PRP in this case.
Okay.
Because of the volume, like we need to understand the volume of the ovaries and to understand what will be the most effective treatment we would recommend, and also what are the initial factors, like the initial parameters. If this is a patient with the preserved reserve, then just the exosomes will be enough. If this is a patient for whom we really need to work with the activation and with the creation of the new potential follicles, then the stem cell treatment will be an option number one, of course.
Okay. That means any two we can do at the same time, a stem cell exosomes or else PRP and exosomes.
Yes, correct.
Okay, thank you. I'll come after a few minutes.
Yes, Kimi, you were the first raising your hand. Can you please ask your question?
Yes, on your first case study, your second case study that you shared, the woman had 4 IVF retrievals with a PRP, the first with exosomes, and then the others were regular PRP. And then at the bottom, it says that she had the MST on. It looks like you were banking all of the zygotes from those 4 cycles and then did